Ready? You've taken your first anatomy exam. How do you feel? Is it about what you thought? Yeah, I would say that you all have a shorter amount of time to learn some of this stuff. So, I would say that like the level of intensity that you would see, like the questions I would write for you versus the questions I would write for the meds, many of them are very similar in like intensity peaks, but I have to give you fewer peaks naturally, just because you just don't have as much time as the meds to deal with it. But hopefully, I know that the content that you'll see will benefit you in future endeavors in professional schools. I mean, all these lesions, just classic kind of gross anatomy lesions. So definitely stuff I would keep in your back pocket in some random, junk drive somewhere. Could pay off again in the future. So I think this exam will feel very different. Like I said up front, anatomy is not a monolith. It feels very different from exam to exam. So this exam, so we're moving away from extremities and into the guts. So we're getting to the thorax and the abdomen for this exam. So I'll teach the thorax. Dr. Bigger will teach the abdomen. It's a pretty common type of combination, a TAP exam, thorax, abdomen, pelvis. So you guys will do pelvis with the lower extremity. So a pretty classic layout. The challenges that I think you'll find for this exam are very different from the last exam. Many people like that. Some people don't. They end up doing both, and after the dust has settled, they're like, yeah, I prefer muscles. But a lot of people don't. A lot of people don't like I didn't. So I was not a fan when I took gross anatomy, because muscles mean a lot of factoids, you know what I mean? It's just a lot of facts. So in order to solve really fun and interesting clinical problems, if you have a nerve lesion, you have to know which muscle it's innervating, and then also the origin insertion for the muscle, so you can know the action, so that you can then predict the deficit, right? So you have to know like 4 facts in order to get, to be solid on the questions. It's not complicated, but it's like, it's just a deep ditch to dig. I think you'll find with the thorax and the abdomen that this is a little more conceptually challenging, I think. So it's a little bit difficult to wrap your mind around some of the 3-dimensional relationships. Also layers, like we're just creatures of layers for sure, and the layers will really kind of rear their ugly heads in the thorax and the abdomen. If you get stabbed in the 5th intercostal space from a lateral side, which lobe of the lung, which 5 layers will be penetrated, which layers will be different from the front to the back, and all that's very important, right? For solving clinical problems, people coming in with these complaints and these issues and these traumas and etc. Okay, so but very different stuff in the thorax. So today's lecture is not too bad, just kind of kicking off easy. And then next week, so we're on the schedule for heart and lungs. So Elena will give the lecture on the heart, and then I'll give the lecture on the lungs right behind that. And we'll get moving right through. So to begin with the thorax is the portion of the body basically between your neck and your abdomen. So the thorax is bound by the ribs out here, and the sternum, and the separation basically of the thorax from the abdomen, which will be below, is this bit of skeletal muscle, this large sheet of skeletal muscle called the diaphragm, or more technically the respiratory diaphragm. So this is the partition essentially that keeps our thorax and our abdomen separate. And the diaphragm, along with the linings on the inside, it's got to seal it off. I mean, your thorax shouldn't really be in any kind of communication with your abdomen, except for the tubes that you have to pass through. You shouldn't have any leaks or cracks or anything anywhere. So the pleura and stuff that line the lungs, they should serve as a nice seal between the thorax and the abdomen. Breaking down the skeleton of the thorax. So looking at the skeleton again, ribs and sternum. If you find the ribs will sort of swing around like this, and they all have kind of the same shape, but they change subtly from top to bottom. So if you were to I couldn't look at a rib and tell you that's rib 7, that can't be rib 8. But just because from person to person they vary quite a bit. There are features that are characteristic of them that may help. Everyone should always be able to pick out rib 1. It's just very different looking. But the ribs, of course, are going to protect our viscera from any, potentially penetrating objects and things like this, and also just provide some structural support, around those viscera, give things some scaffolding basically to hang on. And you'll also notice that the ribs don't come all the way around. So the ribs don't really come all the way around. They'll actually connect to the sternum here in the midline via these cartilages, these costal cartilages. So if you kind of palpate next to if you can feel your sternum here in the midline and just palpate out next to it, like for several inches out here on the outside, it's just costal cartilages. And you can just cut you can just cut through these things like butter. We have these garden shears. You just go right through. So really the skeleton of your ribs stop right about where the mid-clavicular line would be, somewhere about there. And from there, it just reaches over via these cartilages. And part of the reason we have these cartilages is for mobility. So your thorax is moving as, changes in volume and stuff in your thoracic cavity. So it can't be too rigid. It needs to have a little bit of motion, a little bit of movement. And sometimes these get too movie. Actually, a very common complaint in even primary care settings, my wife sees this all the time, is costochondritis. So costochondritis, this can happen even in very young people. Just irritation, at the junction where the ribs and the costal cartilages are right there. So some irritation. A lot of times it freaks people out because it's like, oh, I'm having chest pain. But it's usually triggerable on movement. So you can challenge the ribs to move around a little bit, and you can confirm it's related to the skeleton. So we talked a little. We know about the vertebra. Generally, we know we have these costal facets and everything. These demifacets on the thoracic verts. Remember, the head and the neck of the rib will go in there. More on that in a second. Tubercle. And we see this angle. So the angle is called costal angle. The costal angle is not like a single point. It's just basically where the rib starts to turn and go forward. Some generally lower ribs will have a little bit better angles than the higher ribs. The body of the rib here as we swing around, and there we can see the connection with the costal cartilage to the sternum in the midline. There are also some holes. So there's some big holes in the thoracic cage here. So this hole at the top here is called the superior thoracic aperture, is aka the thoracic inlet. Okay, so the superior thoracic aperture, thoracic inlet, and then this big hole, if you were to trace the line around the edge all the way around the back, would be the thoracic outlet or the inferior thoracic aperture. So there's some disagreement among different literature. So a lot of clinicians would like to call the superior thoracic aperture the thoracic outlet. You may have heard of thoracic outlet syndrome, but it's just sort of a tomato thing. But for our purposes, we all have to have the same story. So the superior thoracic aperture will be called, aka, the thoracic inlet here, and then the outlet will be aka the inferior thoracic aperture. Okay. A little overview of ribs and how they may be different. So we've got to talk a little bit about this. You can break ribs up into there's different ways to group them, I guess you could say. One commonly way to group them is true versus false ribs. Another way of grouping them is typical versus atypical ribs. Kind of like we looked at typical and atypical vertebra. We looked at typical vertebra, right? It's got this vertebral body and a vertebral arch, lamina, transverse process, all that. So kind of the same thing for ribs. So you'll have ribs that share similar features. We call these typical, and some which they're kind of deviating from that plan. So true versus false ribs. So you can see the ribs will swing around. So 1 through 7 here. And when they swing around, they have a nice little costal cartilage, just like we expect, and it'll come up and make an attachment here with the sternum. You can see ribs 8, 9, and 10. They have costal cartilages, but they don't make a direct connection to the sternum. They're all sort of fusing together down here. So 1 through 7 are called true ribs because they're making these, 1 through 7 makes the true connection here to the sternum. And 8, 9, and 10 are called false ribs. So 8, 9, and 10 are false because they're technically not making a direct attachment to the sternum. They're attaching indirectly into the costal cartilage here of 7. And then down here at the bottom, everyone's heard of floating ribs. Yes, you've heard of floating ribs. So floating ribs are ribs that don't make connections at all down here. They're just poking out. So ribs 11 and 12 are floaters. They're floating ribs, so they don't make any distal connections. They just kind of hang out back there. Other important terms that you may hear, subcostal angle is just referring to the angle here along the two costal cartilages where they're connecting. And a more commonly used term that you see more, in the clinical types of anatomical applications is costal margin. So the costal margin would just be, if we tell students to make cuts along here, just palpate the costal margin. It's important for, IDing things before, for example, like pericardiocentesis, like, the things that procedures and stuff like this in the area. Digging in on the ribs just a little bit more. So your typical ribs, your typical ribs are 3 through 9. Some books say 3 through 10. We're just going to go through 3 through 9 because that's what our book says. It's got a head and a neck. So head is a big part. Usually has 2 facets, and those 2 facets, remember, will correspond with the demifacets that you see on the vertebra, right? Those little costal facets that you saw on the thoracic vertebra. So that's where they would plug in. In addition to that, you usually see a tubercle. The tubercle on the rib will articulate with the transverse processes facet. Okay. And then we swing around, we see the big angle, body, and something that's notable on the rib, and this is a good way to tell a rib top from bottom, because when you look at a rib, it can be a little bit confusing, like which side is it top or bottom, is to look at this groove along the underside, which is relevant, called the costal groove. So the costal groove is like this notch that is carved into the bottom of the ribs, where an important neurovascular bundle will run. Okay, so there, for example, we see rib 7. Rib 7 with its little facet, superior and inferior facet, making that articulation with the costal facets, superior and inferior costal facets on 6 and 7. And then the tubercle of rib 7 will articulate with the transverse processes facet on vertebral body, or on the vertebra 7 there, okay, on the transverse process. So 7th rib and demifacets on 6 and 7, 7th rib on the tubercle here on the transverse process of 7. That's how they are arranged. So those are typical features. So atypical ribs will be just, of course, the remaining ones. We have 12 total. 3 through 9 are typical. Ribs 1 and 2, and then 10 through 12 are considered atypical. This is another way of thinking about them. If you look at rib 1 over here, rib 1 is definitely the easiest one to pick out. It's very short, very broad. Just has a single facet hanging off of its head there for just one articulation. And you'll notice a tubercle, so-called the scalene tubercle. If you recall back from the MSK that we just did, and the scalene triangle, right, where the brachial plexus and the subclavian artery and all of that are pouring out of there, the anterior scalene muscle, which represents the anterior boundary of that, will attach right there. So the anterior scalene would attach here, and then the subclavian vein would run anterior to it, becoming the axillary vein, and the subclavian artery would run in that groove posterior to it, just like that. So, and that checks out. That's what we see when we look in the donor, and that makes sense. So the brachial plexus would also pour out there posterior there with the artery. The second rib is, so we have head, neck, everything like that. The second rib is notable for a tuberosity for the serratus anterior. So serratus can go down and bite down on lots of ribs, usually 8 or 9 ribs for its insertion. And I don't know why, but on the second rib, it just likes to have a big tuberosity there for its attachment. So that kind of makes rib 2 stand out. So technically it gets categorized with the atypicals. Rib 10 there, just one facet on the head for rib 10, so it doesn't articulate with 2 vertebrae. It would just go to 1 vertebra instead. Not too big of a deal really, but nevertheless, it does make it stand out just a bit. And then obviously ribs 11 and 12, they stand out. One reason, right, they're floaters, right? They're floating ribs like this. They don't have really a notable neck. They don't have really a tubercle either. And 11 or 12 is so short, actually. This is rib 12. I saw it the other day. I was like, that's rib 12. So you can see it right there. So a little rib. So rib 12, very short. So it's so short, there's really not much of an angle because it's not very long, and it just hangs out back there. So we're in the belly and stuff dissecting. You can lift up the viscera and everything in the abdomen and just use your finger and push you can feel like the edge of where the floaters are underneath there. It's kind of like the little piano key waiting to be pushed on. Okay, so the craziest thing that happened to me in the year of 2022 was I was in the lab dissecting, and there's a student group that was like, yeah, we don't know what this is, we don't know what this is. This happens all the time. So I go over and I'm like, what could this be? They're dissecting the gluteal region. And I'm like, it's a fun dissection, I really like it. The gluteal region is underrated. So it is, right. It's true, we'll get there. I'll give you the gluteal lecture, you'll see. So so I'm over there looking, and I hit something like really hard back in the gluteal region. They got gluteus maximus off, so it's reflected back, and I'm tapping. It's very hard. My first thought is like, well, they probably had a posterolateral hip replacement. Our donors are old, right? So they have hip replacement. So it's not uncommon to see this. So I start dissecting in there, expecting to find some titanium, and I do not find titanium. Instead, I find a bone. I find a bone projecting into the space between the gluteal muscles, where there should not be any bones. It's in your butt, okay? So I follow it. I'm just dissecting this bone. I'm dissecting it out, and this thing attaches to the sacrum. I was like, oh my gosh. So this was an embryological emergency because I went and got our embryologist, and she like passed out. I was like, oh my gosh, it was such a big deal. So this person had sacral ribs. They had ribs growing from their sacrum into their gluteal region. So I don't like to do a lot of case reports just because it's just, you don't want to be king of the case reports, but it's there when you find a good case report, you need to do it just because it could be a meaningful contribution to the literature. And I did, buddy. So I took our donor, I took her to the hospital and scanned her in the CT scanner, and this is a 3D reconstruction of that. So you can see just this like platform of bone that was extending away from the sacrum with these little projections coming away. So little ribs growing right off, just like that. And she even had some ones floating kind of underneath in what's called the sacrotuberous ligament. So this is a gross picture of that. So this is the rib here. This is the gluteal region. This is like the side of your butt. So this is those ribs there just hanging off. Pretty wild, right? This is the coccyx right there. Okay. And I don't know if this person ever knew that or not. They were like 70 something. So if you're a consumer of I think we published this in Folia Morphologica. You'll see it. You'll see it when you get in there if you haven't read it already. I'm sure the mailman will deliver it to you. Crazy stuff. All right, so just some real pictures of these, just so you can say you've seen them. They're rib 1, right? Rib 1 always stands out. It's pretty obvious, very different from some of the other ribs. And you can see there are gradual changes as you move from top to bottom. They're rib 1 all the way down to rib 12. Sometimes you get nice angles, like I see here's a nice angle. Sometimes it's a little more smooth, a little less angly. Okay. Ribs, very important. All right, so let's talk about the sternum then. So the sternum has different named parts. The upper part of the sternum here is called the manubrium, and the inferior part here is called the body. So body and then manubrium. But then hanging off the body is this little process here called the xiphoid process. And at the top of the manubrium, you'll notice a couple of notches. There's one notch where your clavicle goes. So this is where the sternoclavicular joint would be. It's the clavicular notch. And then there's a notch that's dead center right in the midline called the jugular notch. So if you like take your finger and just kind of palpate over the top there, you can feel the clavicle on either side, right? You can palpate your clavicle, and your finger will be going into the jugular notch right there. It's kind of uncomfortable. There's actually nothing. There's like nothing behind there except for some thin muscles, and then right to your airway. Your airway is like right behind there. There is a very important anatomical location here, which is the merger essentially of the manubrium and the body of the sternum, called the sternal angle. The sternal angle. So the sternal angle, or the angle of Louis, if you like, is associated with rib 2. So I see rib 2 here coming around. There's this little cartilage, and right there is where it's going to talk to the sternum. So the sternal angle is associated with rib 2, and it's at vertebral level 4-5, T4-5. So we'll talk more about that in a minute, but it's an important landmark for lots of reasons. Rib 1 forms a synchondrosis, whereas the rest of these will just be synovial joints here. So these joints, between the sternum and the ribs, have to have some mobility. So they are technically little tiny synovial joints, so they're not too rigid, really. They need to be able to move around some. So picture of a sternum. Cool. xiphoids hanging off the bottom. Xiphoids come in all shapes and sizes too. So statistically speaking, there's a significant minority of you in here that have a bifid xiphoid process, which is always kind of weird to find. They just come out and like they fork into two like a snake tongue. It's pretty crazy. All right, so that's good. So we talked about the bones. We know what the rib cage is made of. Let's talk a little more detail about the diaphragm. So the respiratory diaphragm here. This is an interesting little muscle. So the diaphragm has these attachments. It's got to be latched on there. And where it's attached is basically along the bottom edge where the costal margin is, going all the way around, attaching onto the vertebra, onto the vertebral column in the lumbar spine, and then wrapping back around to the other side. So it needs to be attached all the way around like this, so it kind of seals off, top or bottom. And it doesn't really, you can see it's shaped like a dome. It's kind of just shaped like a dome. It's not really, this is a top-down view right here. So it's just kind of coming up like this. And so it doesn't really have like origin insertion would be a weird way to think about it. So it just has, I guess, attachments, I guess you would say would be really the best description, going all the way around. And instead of having some insertion in some other site like we're used to dealing with, it just all sort of converges on this large, broad, flat tendon up here called the central tendon of the diaphragm. So when you shorten these muscles, you can imagine if you were to shorten the fibers of the diaphragm, where's it going to go? Up or down? Yeah, it goes down. So it's going to go down because it's attached along the bottom here. So when it goes down, it's going to change the volumes in the abdomen and the thorax, right? Because you're just moving the partition between the abdomen and the thorax, so naturally the volumes are going to change. Important things that you'll see if you were looking down on the diaphragm here, aside from the central tendon, you'll notice these three holes. We like these holes. Everyone should know these. One is the cable foramen, which is a little more on the anatomical right. This is the top-down view. One closer to the middle is called the esophageal hiatus. And then it's not really a clean hole through the diaphragm like you see these other two, but the aortic hiatus is essentially a hole, if you will, but really it's just an opening behind the diaphragm. So you could probably guess the aorta will sneak behind the diaphragm through that hole. So the cable foramen and the esophageal hiatus are just like proper holes. They're like clean holes going through the diaphragm. And the aortic hiatus is just kind of like an opening behind the back of the diaphragm. So these are important. These are good to know. So this is a bottom-up view. So this is a bottom-up view now, and you can see those same three holes. So on the anatomical right, we see the cable foramen, right, cable. And then we see the esophageal hiatus, and then we see the aortic hiatus. Attachments-wise, the diaphragm does have like different parts. So there's a sternal portion, which is quite small. So it's these two little slips here that will come down and attach onto the sternum, notably the xiphoid process. It's kind of small, but you can't have too big of gaps around. The only gaps around the outside that are really big. There's a lumbar portion. So the lumbar portion will come down and attach as crura. Okay, these crura. And you'll also see this portion here that does leave these little arching ligaments. So you have arcuate ligaments, and these little arcuate ligaments, they're not really filled with important vessels, I would say, kind of like these or the esophagus or something like that, but rather it's just muscles that will be squeezing their way through there, like psoas major and the quadratus lumborum muscles. Okay, cool. Okay, so the important part about this slide really is the openings. So these openings are good to know. So the cable foramen and the esophageal hiatus and the aortic hiatus are all happening at different levels, like different vertebral levels. So every student of anatomy should definitely learn this. So the highest of the three is actually the cable foramen. It will come out at about T8 level. So the T8 vertebral level is where you see the hole for the vena cava. So the vena cava is a giant tube. It's big, man. It's like this big. It's really big. So you have an inferior vena cava and a superior vena cava that would meet at your heart. So all of the deoxygenated blood's leaving your abdomen, your lower extremities, and everything like that. It's got to get back into your heart via the inferior vena cava. So the inferior vena cava will go back, plug back into your heart via the caval foramen. So your heart would sit right on top of the central tendon. It sits right on top, it just lays on top of it like that. So as soon as the inferior vena cava gets into the thorax, it's maybe a centimeter long, and it's plugging straight into the heart. You could probably guess the esophagus is coming through the esophageal hiatus, and then the aorta through the aortic hiatus. There are other things that will pass through there, but we'll talk about those more as we proceed. Okay, so the innervation for the diaphragm. Okay, one of the more important nerves in anatomy for sure is the phrenic nerve. So the phrenic nerve is a derivative of the cervical plexus, which we haven't discussed yet, and it gets a little bit of help from the brachial plexus. So C5. Remember, the brachial plexus is C5 to T1. So the cervical plexus usually is considered the origin of the phrenic nerve. So the phrenic nerve has some important anatomical relationships. So the anesthesiologists who are all obsessed with these, scalene blocks and everything where the brachial plexus is, anyone doing surgery in the neck, okay, they're very, very mindful of the phrenic nerve. Because if you damage the phrenic nerve, you're going to have a big problem, right? Because the diaphragm on one side may be affected by that, okay? Your diaphragm will drive your respiration, so this could be a big issue. The first relationship I'll point out is the relationship to the anterior scalene muscle. So remember anterior scalene from last exam. We mentioned that there's a little attachment here on rib 1, right? So the subclavian vein goes in the front, subclavian artery is posterior to it. The phrenic nerve passes right over the anterior scalene muscle, thusly. So it's going right over the ventral surface of it. Next, it will go behind the subclavian vein and through the superior thoracic aperture. So behind the subclavian vein and through the superior thoracic aperture, where it will enter the thorax. Now from there, like if you were to crack somebody's, crack their ribs open, lift open the hood, and look down inside, you would see, if there's not a lot of visceral fat, you can see these two little streams that are riding on either side of the pericardium where the heart is. That's where the phrenic nerve is located. So the important thing here is it's passing on the pericardium, but it's also passing anterior to the root of the lung. So the root of the lung is essentially where your lungs plug into your heart. So if you can imagine your heart here in the middle, it's got to have some pipes coming out of the side that's going to talk to the lungs. We call this the root of the lung. Like if you were to take your fingers and grab around all the pulmonary artery, veins, bronchus, all that. So if you're considering those pipes coming out sideways, going in front of the root of the lung will be the phrenic nerve, and the vagus nerve will go behind the root of the lung. So it's kind of the last really important relationship to know there. Cool. So it does help with part of the pleura. So the actual pleura itself, which is a lung, like the lining around the lung. So we'll talk about this more later. Some of this sensory information is provided by the phrenic nerve, and also some sensory information from the sac around your heart, which is called the pericardium. So we see there phrenic nerve and that little slip there. So your heart would be sitting here. So you're looking down. I can see where the caval foramen would be, right? Esophageal. There's aortic. And I can see the heart would sit here and your lungs would sit on either side. And there's linings on both of those. And that's why the phrenic nerve looks sandwiched between these two connective tissue layers, because there's one around your heart and there's also one around your lungs. So it's sliding basically between those, just like that. Okay, so 3 pretty important relationships there for phrenic nerve. Phrenic nerve, C3, 4, 5, keeps the diaphragm alive. C3, 4, 5, keeps the diaphragm alive. So phrenic nerve injury in a chest x-ray would look something like this. So normal chest x-ray, you should see the contour of the diaphragm like this. I can see the ribs swinging around, and we'll have more on chest x-rays, so we'll get pretty good at it. But I can see them swinging around. And the heart would be sort of favoring the left side here just a bit. I can see that short, ugly rib 1 right there. There's clavicle. And this guy, right, there's the scapula, top of the scapular superior angle. So if you have a lesion to the phrenic nerve, then you could expect one side of your diaphragm not to work. So, and this is exactly what you would see. So if you lose the tone to the diaphragm and it's not able to pull itself down where it should be, then this is going to float up like this. Okay, and this could cause you some sort of issues here. I mean, it's not like you would die right away, so this may be, you know, manageable clinically, but it's something they're not going to leave alone. Okay, so you're looking for asymmetry here between these. It should be a little more like this. And this guy down here is normal. Does anyone happen to know what this is? Any guesses as to what this may be? Anyone had any medical imaging before? I'll give you a clue. It's an air bubble. Where do you think it's at? It's right. That's the gastric air bubble. So they look for a gastric air bubble in your stomach. So I know that that's below where the diaphragm would sit. So assuming the patient's not standing on their head, in which case the bubble would be on the bottom of the stomach, the air would come to the top of the stomach and kind of sit in the fundus. So this is a normal finding. Talking about movement of the rib cage, so there's a couple of important movements to understand. So one, why does our rib cage need to move? So remember, our rib cage needs to move so we can help change volume, so relative volume in the thoracic cavity. So there's a couple of ways it can move. Actually, we'll talk about that part first, then we'll go back. So on this slide, I think it's easiest to start with this. There's two primary movements for the rib cage. One is called a pump handle movement, and the other is called a bucket handle movement. So the higher ribs, usually 2 through 6, are associated with pump handle movement. And so if anyone has, you know, I guess if you watch like Westerns or something like this, people used to get their water out of these little pumps or whatever like this. Anyone do it? Anyone do this? Anyone get their water from a pump? Do you still? At the barn? Sorry. Sorry. I don't have a barn, so but you're basically cranking out like this. So the movement is kind of, well, there's an arrow there to describe this, kind of being displaced this way, kind of like a pump handle would be if you're at the barn. Perhaps also at the barn, there might be some buckets. Let's just keep going with this. This is good. So there might be some buckets down there. And I know everyone's picked up a bucket. So, you know, if you pick up a bucket and you're like, if it's laying against the, you know, the actual bucket, the handle's laying against the bucket, if you pick it up, it sort of swings out like this. Yeah, it's got to like clear the edges of the bucket. So this bucket handle movement is more attributed to the lower ribs. And in doing all that, what can happen is you're changing the volume in the thoracic cavity. It's as simple as that. So I fortunately there's not much math in anatomy. That's perhaps why I teach anatomy if we're getting like down to it. But does anyone remember PV equals nRT? Oh my gosh! Wow. Here it is. This is the only equation I know. Right. It's like when I talk about this, I talk about the relationship between volume and pressure, right? So if your thoracic volume is whatever it is like this, and you increase the volume, so what would happen to the pressure if you increase the volume in the thoracic cavity? Yeah, you're going to decrease the pressure. So your diaphragm, the only thing it knows how to do is go down, right? That's based on its little attachment around the edge. So when it fires, it's going down. So your thoracic volume is increasing as the diaphragm goes down. And the pressure on the inside of your thoracic cavity, notably in your lungs here, right, will go down. So volume is increasing, okay, pressure is decreasing. So the pressure on the inside of your thoracic cavity relative to the ambient pressure is lower. So air just rushes in. Okay, you don't really have to try that hard. It's just doing it because the pressure on the inside versus the outside is just different. So similarly, if you're expiring, if you're doing like forced expiration, like this, does this make sense? Okay. I think you get it. Now talking about this, you can have accessory muscles of respiration. And the accessory muscles of respiration are not active all the time. It's more like, this would be interesting clinically if you had people who are under like respiratory distress. They teach like pediatricians to watch this in kids who may not be able to verbalize their problems very well. But you can kind of see some of these muscles working, not all of them, but some of them. So since the diaphragm is your primary driver of changes in the thoracic cavity as far as volume, and therefore driving your ventilation, being able to move air in and canal, simple as that. You can exaggerate this more if you need to. So there are some muscles to discuss with this. One is the serratus posterior muscles. Yeah, so everyone remembers serratus posterior muscles from last time? So the serratus posterior muscles, there's a serratus posterior superior and a serratus posterior inferior. So that's all good. That was in the intermediate layer in the back. We know they're going to come down and they insert onto the ribs here. Okay, it's not the greatest picture. It looks like it's kind of behind the scapula there, but it's inserting onto the ribs. So if you were to shorten these fibers, you'll pull the ribs up, right? So this will increase volume, decrease pressure. So the serratus posterior inferior would just be the opposite. Okay, pulling down. So if you're pulling them down, then you're activating that bucket handle movement kind of down, which would decrease volume, increase pressure, so it would be more like a muscle expiration. Also, pec minor. So pec minor is an interesting muscle in that it can actually reverse its origin and insertion. Most muscles we only use one way. Like the whole time, forever in your entire life, you've only ever had biceps moving on and activating your radius, like ever. That's all. I mean, the only other option for biceps here, if it's not going to pull the radius up, its only other option would be to pull the scapula down, which is bizarre, right? I mean, so like, if you imagine like your radius is fixed here in place and like your whole body just like, that's not how it works, right? Not all muscles work this way, and sometimes it's actually pretty consequential. We'll talk about when we talk about bipedality and walking and stuff like this. Some of your gluteal muscles will reverse their origin and insertion based on if your legs are in contact with your feet are in contact with the ground or not. So pec minor is the same kind of way like this. So insertion up here, technically by the book, would be up here on the coracoid process, which would help, quote unquote, fix the scapula. It's not terribly important. I mean, we know it's not because surgeons will sack this muscle regularly to help patients with other nerves that they might need. So like the medial pectoral nerve, which helps innervate pec minor and pec major. A lot of times they'll use that to fix another nerve that may be damaged. So they will just cut like the medial pectoral nerve, pec minor is gone, and they may transplant the nerve, graft it into an injured nerve, like the musculocutaneous nerve, to help restore their flexion or something like that. Pec minor is interesting though, in that if you're fixing it at the scapula, maybe by using other muscles to hold the scapula down, so like, for example, like trapezius and latissimus. Latissimus will come by and like hug the bottom of the scapula, attaching into the humerus. So if you're firing it really hard, it's almost kind of like you're bearing down like this and keeping your scapula fixed. Then when pec minor fires, it just has no other choice but to pull in the ribs, which at that point would be the preferable joint motion. There are some deeper ones. I mentioned these, I think, in the deep back lecture. Levitoris costarum. So the levitoris costarum muscles, they're tiny little guys. They look about like this. So when you pull on these, the levitoris costarum muscles, it would elevate the ribs, increasing volume, decreasing pressure. Okay. Other accessory muscles of respiration, which aren't always active, are the intercostal muscles. So you know enough about anatomical terms here probably to be able to predict what these guys are doing. Right? So they're between the ribs, intercostal. So the term costal referring to the ribs. So you have three kinds of intercostal muscles. So there's an external intercostal, an internal intercostal, and the innermost intercostal. So the external intercostal muscles, we see them here, they start in the back, and they don't quite wrap around to the front. They end about the mid-clavicular line here, okay, about the level of your nipples in the sagittal plane. And the external intercostal muscles are kind of oriented in what we call hands in pockets direction. So they're kind of oriented like this, okay, between the ribs. And then deep to them, we see a muscle that starts in the front but doesn't quite make it to the back. So this is the internal intercostal muscles. And then last but not least, you would see the innermost intercostal muscles. And you can't really see these innermost from the outside. From the outside, I can only see the externals and then the internals running deep to the externals, of course. The innermost you'll only see on the side. So basically, like if you were to take your hands like this, like a lobster claw, and put it on the side, that's where the innermost intercostals are located. So if you do need some extra, maybe you're just huffing and puffing, you just ran a marathon or something like that, then you might recruit some of these muscles to help with this. A good memory device to remember what these things are doing is, if it starts with E, it helps with I, and if it starts with I, it helps with E. So if you're an external intercostal muscle, you help with inspiration, and so external intercostal, inspiration. If you're innermost or internal intercostal, then you'll help with expiration. So inspiration versus expiration. Also, the scalene muscles can be considered accessory muscles of respiration. So if your neck is fixed, these wouldn't be lateral flexors of the neck. Instead, they may elevate the ribs, one or two. Kind of an afterthought. I wouldn't sweat it too much. Okay, so looking closer at the anterior thoracic wall. So this is like someone's cut off the chest plate and flipped it around, and you're looking at the back side of it. Okay, so like the chest plate cut off, flipped around, now we're looking at the back side. And on that back side, you can see some of my intercostal muscles that I mentioned before. They're here. Netter is showing you the edge of the diaphragm where that's attached at. You'll also see a muscle called transversus thoracis. The transversus thoracis. So the transversus thoracis muscle are these little slips, these little finger-like slips that are lifting up, that are reaching up like this and trying to attach to higher rib levels. So based on the attachment there of transversus thoracis, what do you think its action would be? Would it help with inspiration or expiration? It's going to pull the ribs down. Yes, good. Yeah, it's going to help with expiration. So pulling the ribs down, decreasing volume, increasing pressure. So like this. So if you're forcing expiration out, transversus thoracis can help with this. There'll be two very important structures to note that are running on both the front and the back. The one we'll talk about here in the front is the internal thoracic artery. So the internal thoracic artery here is a branch of the subclavian. Remember vitamin C and D from last exam? So vitamin C, this is the I, V-I-T. So the internal thoracic artery, in a former, decades ago, known as the internal mammary artery. So many surgeons will still call it this. So the internal thoracic artery will flank the sternum on either side. So right on either side of your sternum, running all the way up and down there, is the internal thoracic artery. And the internal thoracic artery will intermittently give off these branches called anterior intercostal arteries. So the anterior intercostal arteries, and you can see they're on the front and they're going between the ribs. So we call these anterior intercostal. The internal thoracic artery continues down, okay, and just before the xiphoid process usually will terminate by splitting into an artery that goes onto your stomach, okay, into the subcutaneous tissue of your abdomen, called the superior epigastric artery. And it'll also give off an artery going laterally along the costal margin called the musculophrenic artery. So the musculophrenic artery sort of takes over and helps provide anterior intercostal branches after that. As the name implies, it's also going to help with the diaphragm. When you see the term phrenic, you're thinking diaphragm. And this results in a very important relationship here. Let's see if I got the next picture. No, so I'll show you in both places. There's a relationship here of a vein and an artery and a nerve. So the vein and the artery and the nerve, we call these intercostal vein, intercostal artery, intercostal nerve. They're running in that costal groove. So there's that, remember that groove at the bottom of the rib? So if you look over here, you can see that groove there carved into the bottom of the rib. And more classically, these are known as the Van bundle. V-A-N. So from top to bottom, it's a predictable pattern here. The vein will be first, then the artery, then the nerve. So if you're doing a nerve block here, and you want to block one particular level, you could feel for the bottom edge of the rib, and then anesthetize like right at that level with an anesthesia. These do give off collateral branches, and I hate they even put this in here because they've drawn this thing like the same size as the other one. So collateral branches here are extremely small. They're almost irrelevant. I wouldn't sweat them too much. So the intercostal nerve, as you see it labeled there, is about the size of a linguine noodle. It's serious. It's a really big nerve. So if you're doing an anesthesia, they usually definitely try to get that right under that costal groove. Does that make sense? So you're going to hit that nerve. Now, on the other end of the spectrum, if they're doing a chest tube, then they want to try their best not to hit that guy. So when they put the tube in, they usually feel for the top of the rib. So they'll put the tube in over the top of a rib like that because they know they won't hit the intercostal nerve. They may hit a collateral branch, but it's not, that wouldn't give the patient anywhere near as much grief. Okay, kind of a painful thing. Now, there's two origins for these arteries. Remember, the internal thoracic artery is on the front side. That's the one we mentioned. It's going to give off what's called an anterior intercostal artery that we just saw, part of that Van bundle. Well, these anastomose, they anastomose with an artery in the back. So the aorta is coming down the back side, And the aorta is going to give off posterior intercostal arteries. And I see it there. So those are posterior intercostal arteries. And they would just wrap around. Here's a good picture. So they wrap around like this. And you can just see they'll anastomose with the anterior intercostal arteries. Almost like making one continuous tube all the way around. Now, so that's how our arteries and veins are arranged. You have posterior intercostal arteries from the aorta, and you have anterior intercostal arteries from the internal thoracic, and a little bit from the musculophrenic that we mentioned. Of course, you only have one spinal cord, so there's only one place where the nerves can arise from. So the spinal cord back here is going to give off these intercostal nerves, which would reach all the way around. That's the N in the Van bundle. And when these nerves, these intercostal nerves are coming through, they're just ventral rami. So word you might remember, the ventral rami, remember, mixed to make the brachial plexus. These ventral rami at each one of these levels, so T2, T3, T4, T5, all the way through here. These intercostal nerves, which are just ventral rami, do a full thickness innervation, meaning that from inside all the way out, these intercostal nerves are innervating everything. They're innervating all of the muscles, all of the skin in that single zebra stripe. Okay, and then the one underneath it would do the next zebra stripe. All the skin, the subcutaneous tissue, all the muscles, everything. So full thickness innervation. Okay, so this is relevant. This is relevant because the dermatomes that we get are dedicated then to each level, right? You have a dedicated level of the spinal cord that's going to do this little zebra stripe, doing the muscles, but also doing the skin. It's doing the skin there. So this is related to shingles. So everyone's heard of shingles probably. So who in here has had chickenpox? You? Yeah. Me and my brother both. Nice. Yeah. So I have chickenpox too. So chickenpox, most people are immunized against it, I guess, now, which is great. But if you've had chickenpox, then you're a candidate for shingles, so cropping back up. And I would say my wife sees a lot of shingles in younger people. She's, I think, surprised by that. When you teach it, it's like, oh yeah, shingles comes back when you're old and stressed out, you don't have an immune system. But I guess young people are sufficiently stressed enough to where no one can buy a home anymore. I think that's what it is. I think that's what it is. So what happens is you end up getting this shingles will come back, and you get this reactivation of the virus, and this reactivation of the virus, which lives in the DRG, it's inside of the dorsal root ganglion at that level, will reactivate along that dermatome. So you get a rash that mimics the dermatome. And there's a similar rash you can get on the face. So you basically have a big DRG for your face sitting inside your head. So you can get rashes distributed over different parts of the cranial nerves as well. Okay, so shingles. Yikes. Another important clinical correlate is with the internal thoracic artery or the internal mammary artery. So the internal thoracic artery is pretty much now the going favorite for coronary artery bypass graft, or a CABG. So we see these all the time in the lab, coronary artery bypass graft, because we're all clogged up and we're eating a lot of McDonald's, and cookout, I guess now is like the big thing. So who has had cookout here? Where the cookout exists where you were from, if you're not from here? Yeah? Anyone not from here without cookout before they got here? It's kind of complicated. So you just saw cookout for the first time?
Well, no, I've seen it before, I just chose it.
That's okay. I mean, like, what do you think about now, though?
Oh, I still have
Like on Yelp, like, what if they left? What's that?
Not impressed by it.
Well, it's like $1 for a quesadilla. I'm sorry I asked. Okay. Anyway, so basically whatever you're eating, it doesn't really matter because it's going to clog up your arteries. So all the arteries, the arteries that are like covering your heart, the vascular supply to your heart is obviously very important. And if one of these vessels, so one that likes to get clogged a lot is this guy. So this is the RCA, the right coronary artery. If this is clogged up, a lot of times in lab, I'll like crack open a chest. A lot of times I get it clear because they're wired shut here in the front. They've done a sternotomy. And you can get to their aorta, you see all these little stitches where they stitch in another artery, or sometimes they just leave the internal thoracic artery from its origin, and they just leave it. They just leave it there, and they'll just pipe it over a structure. So if they use a graft like the great saphenous vein or something like that is a common one to use. Sometimes they'll use internal thoracic and just pipe it right over like this. So it's essentially going to be jumping the area where the clot is and perfusing the tissue. So coronary artery bypass graft. Just a couple quick words about the thoracic cavity, sort of a prelude to what will happen next time. So we talked about like the outside, the thoracic wall, etc. So what happens on the inside? So on the inside, it's actually pretty simple when you're just talking about the organization. You have a heart in the middle and a lung on either side, which is great. So the lungs are lined by these pleura. So you have what's called parietal pleura that are lining the lungs out here on the outside. And this kind of keeps them within their own sac, if you will. And we call these two parts, like if you were to pull the lungs out, the cavities that they sit in, the pulmonary cavities. And in the middle, between the lungs, is a large area called the mediastinum. And the mediastinum has subsetted parts. So the most famous component of the mediastinum is where the heart would sit down in here, but all this central portion is the mediastinum. And I told you this would come back to haunt you, but the mediastinum is separated into these different parts, notably above from below, so the superior mediastinum from the inferior mediastinum by the sternal angle. So the angle of Louis, which everyone remembers is between the manubrium and the body, would be right at about T4-5 level. Okay, so we're at about T4-5 level. And like I said, this separates the superior mediastinum and all the stuff that's in there from the inferior mediastinum and all the stuff that's in there. Now the superior mediastinum is just that. The inferior mediastinum has three subparts: an anterior portion, a middle portion, and a posterior portion. Okay, so it's very common to get test questions that are like, all right, this person has a tumor in the posterior mediastinum, which of the following structures most likely affected. So at first it's a bit of just kind of knowing what's in there. So this is a kind of a 30,000 foot view, and then we'll dive into it more. So when you talk about the heart, and you talk about the lungs, we're just filling in these gaps with greater detail. So there's angle of Louis, so superior mediastinum. Look at this stuff in there. My gosh, it's busy, it's busy. So the first thing we'll talk about is thymus. You talk about this in immunology, thymus. So thymus will be up there, so this is north of the sternal angle. What we call the great vessels will be up there. Vessels that are entering and leaving the heart. So really big pipes coming in and out of the heart. The trachea will be in there. The windpipe is in there. A structure of a lymphatic structure, the largest lymphatic duct in the body, actually. The thoracic duct will be there. And of course the esophagus is passing through. So the esophagus likes to sit behind your trachea. All right, so in the inferior mediastinum, there's three parts of the inferior, right? So the inferior mediastinum can be broken up into three parts. In the anterior mediastinum, there's not much going on. So in the anterior portion of the inferior mediastinum, there's not too much going on. Like your internal thoracic artery and vein would be in there. If you're a kid, like if you take like an x-ray of a kid, like a chest x-ray, bro, this thymus is popping. It is huge. It is massive. So the thymus in a kid is just wild. It's really, really big. And of course, it regresses over time. So you might see a little bit of thymus in there, but it's more dominant in children. So anterior mediastinum, kind of boring. Definitely the middle mediastinum is where everything's happening. So the heart's in the middle mediastinum. It's surrounded by this sac called the pericardium, which is thick. It's a very thick sac. And you'll also see the bottom of the great vessels, what we call the roots of the great vessels. So the great vessels that are leaving the heart, the aorta, the pulmonary trunk, all these sorts of things, they would be seen in the middle. Posterior mediastinum may be the busiest of them all. So you'll see the trachea has split at this point, so you don't see it. There is no trachea in the inferior mediastinum. The most important ones to remember are the thoracic aorta, so the aorta that's coming around and looping down. It's got to get to your legs. So the aorta will be in the posterior mediastinum. It's buckled right against your vertebral column, like on the like favoring the left side just a bit. The thoracic duct, the same thoracic duct as you see in the superior, is just traveling up like this. The esophagus, it's got to go all the way down. So the esophagus is both in the superior and inferior mediastinum. And then a venous system called the azygous venous system will be back there to help to drain the blood supply in the thoracic wall. So we'll kind of keep talking about this. Well, Elena will in the next lecture, and then I will with the lungs. Okay, that's enough. So we'll see you Tuesday.